we have a kind of a different collaborationship, Iñaki and myself, or we self, Patrick and myself, because Iñaki has his office, his practice in Spain, and we have our dental laboratory up north in Belgium. And you will see that it will work. So Iñaki, I give the word to you now, and you can start with your case.
You want to get rid of it. So we'd like to present you a case, and this is basically what we see every day, complications. And this patient comes from south of Spain, and basically she got the bridge that you're gonna see just a few months ago. And she's crying. She's coming to our practice, desperate with her problem. And as you are seeing from the far, it looks almost okay. But once we get closer, you will see the disaster. So basically, we have a bridge from canine to central incisor. And just underneath, we have implants, one buried implants on number 12. And this is the situation. The bridge is just cemented on a central incisor and canine and has an intermediate abutment on the implant. The canine is leaking. There is no furl effect. There is mobility. So basically, the bridge is just only cemented on the canine, on the central incisor, on the implant, and on the natural tooth number 21. As you can see, we have a big defect, no gingiva, just a frenum there that is bothering everything. You can see that the differences in tissue level, and especially interproximally, the challenge to really become closer to the contralateral side. So it's tough decision to come up with a real treatment and come up to something that we could feel of all that pink aesthetics, having implants below it, deciding if maybe those implants need to be extracted, if they have to be kept, in order to come up with a volume that could decrease the recession on the first premolar and on the three anterior teeth, and come up to pretty much level that soft tissue that this may be the most difficult one, in order to create that symmetry from both sides of the midline of the face of the patient and the teeth. So the idea here was to come up with more information from a simple panoramic X-ray and see the orientation of the implants to really decide which would be the ideal treatment for this patient. And obviously, this is directly related to your knowledge, your dexterity, and this is the situation. You see the buried implant on number 12, and you can see the orientations of the implants, the red arrow compared to the blue one. There is nothing in common at all. And usually have learned that whenever we have an inclined implant, the better you will be is to take it out. So in this case, I was planning to maintain it because they were really well integrated. One of the main reasons for me to extract an implant is if they have preimplantitis. It was not the case. For me, preimplantitis is I push the tissue, I have pus and blood coming out, and it was not the case at all. So in the first thinking, it was to decide to maintain it. The situation is difficult because the patient has a really high lip line. Soft tissue-wise, I have more mucosa than anything else, no gingiva at all. So a free gingival soft tissue on top of everything will complicate everything. So I decided to maybe, why not come up with a solution, the least conservative, and see what we could do. If you look at the white restorative options, you could go from two single crowns on 13 and 21, 2-unit bridge 11 and 12, cantilever of the number 11. You could do also a 4-unit bridge from 13 to 21 with implants buried on 11 and 12. or the last option that we selected, a 3-unit bridge, placing an implant on number 13 to 11 and placing and restoring one single crown restoration on number 21. As far as the pink, well, you have to make up your decision based on your radiographic examination, sounding, etc., looking at the tissue thickness. You could extract the implant number 11, do a bone graft with connective tissue to compensate the volume lost on number 12, compensate through connective tissue graft all the volume lost, or you could, if this doesn't work, go to pink composite to compensate that papilla that we were looking for and trying to copy. So let's go and see what we did. This is our treatment plan sequence. And sometimes, being myself a prosthodontist and a surgeon, I want to know what is the situation of the abutments, and this is what we did. We removed the bridge, we did a 4-unit provisional, and we did the connective tissue on the tooth and on the implant number 11 to see if we could get thicker tissue to really be able to come up with a higher growth of coronal tissue and thicker tissue to really be able to hide the connection of the implant incisor. Reevaluate that connective tissue, see if the patient needs to do a second one to really come up with more volume, and then come up with the situation, deciding what to do with number 13. We decided to extract it. We would reevaluate to see that we were under control of all the soft tissue, and then do provisionals and finish the case. So basically, this is what we are going to show you. Obviously, in this case, everything went okay, but the first thing was to decide to do a wax-up. And with this wax-up, we wanted to have few ideas, a roadmap about surgically and prosthetically where we wanted to go.
Aesthetically as well.
So in this case, basically, we discussed with Luc all the ideas that I want to redistribute the midline, that it was kind of off, and I wanted to, I had the chance to really do it, so I said, if you can redistribute the midline, control the axis of the teeth, recreate the proportion of those teeth based with...
So in the diagnostic wax-up will guide us through all the processes we have in the lab, so it's like a plan. You can't construct a building without the plan of the architect. This is more or less the plan of the architect, this is the diagnostic wax-up.
So basically, with this diagnostic wax-up, this is the initial, the diagnostic wax-up in the middle, and the duplicate of what we are planning. So basically, we wanted to see on that diagnostic wax-up the volume, how much we need to surgically advance and horizontally too, and do a stone duplicate, so nobody really can tell which one is the implant, which one is the teeth that have been touched and had problems. So with that, we have a provisional that will help us surgically to come up to the next level. Here, everything was tunnel. This was the first surgery, and obviously the tunnel here, we are just creating a really thin cut, because everything is mucosa, so the thickness of the tunnel that you provide on the tissue is essential for the result of the case. Basically, what you're gonna see on this case is a success because the patient had tissue. Usually my favorite donor site is the tuberosity, but the tuberosity has certain ways of manipulating. Is really dense, not too much blood vessels, so we treat it like an alloderm. It cannot be exposed. So some of the most important issues is to create a big tunnel, because here we want to advance as much as possible and create height, not only vertically, but horizontally. So basically, there is not too much literature. Maybe the only good one is comparing palate versus tuberosity. And basically, if I ever take tissue from the palate, I don't take I only take the epithelium. I don't take anything that is below because it doesn't provide me support, density on the grafts that we do. So this is the first connective tissue graft that we took from the tuberosity. One other trick is whenever you want to create and bring height to a different level, is always advantageous to graft the teeth. It's always easier to graft teeth than implants. And usually we take the teeth as a stair, as a point to really increase height to another level. And by density of the tissue, you are able to do that. So this is basically a few shots about the final of the first surgery, where everything is tunneled, everything is maybe the most difficult issue here is to create a pouch and basically have an idea where you are placing that tissue just below without seeing it. So dentistry for me, implantology is about, it's new techniques, it's new ways of, if you open a flap on top of implants, you are increasing the problems. So we reevaluate every 2 months the patient. She's coming from south of Spain. And within that 2 months, she still has sutures. This is what she was wearing, a provisional, to make her happy with composite pink to a different level, more coronally, as you see, if you compare it to the contralateral lateral. And then we transform that same provisional into the situation, and you can see that we need more tissue on the distal and of the implant and in above the provisional and above the buried implant. So you can see that that papilla is created with composite, and what we want is 3 months later, from the first surgery, 3 months later, we do a second surgery to plump out that connective tissue because the patient had that tissue. So you can see that it's another tunnel, and we just place the tissue whenever it's necessary to really bring that tissue to a different position. Why did I create all that tissue, and why the final result is excellent is because I was lucky to have an implant below me, so I could just bring that dense tissue to another position vertically. So we use quite a bit screws to really bring tissue to a higher position. At that time we decided that maybe extracting the canine it would be the best for us because we could manage in a better way the prosthetic situation 2 months later. And you can see that the volume was acquired three-dimensionally and vertically. Now it was a matter of this comparison between the first connective tissue graft compared to the second connective tissue graft and where we are coming from, and the differences between one to each other. So you can see here, in order to come up with all that volume, grafting always the adjacent tooth is something really important. So now we'll have to face the final impressions and how the pressure is so important to come up with something that looks nice. So usually we do 3 types of approaches. The first impression is to take an impression of the final implants that were there to create the abutments. When the abutments have been placed and the tissue has been remodeled, then we will do a third impression of the soft tissue, because we want that soft tissue to be as stable as possible through all the process. So this is the first impression, and with that impression we're going to decide the type of diameter, the type of we're going to change the provisional too. You can see that the implant is not only buccally displaced but also distally, and what we want is to take an impression so we have an idea about how we're going to reconstruct the provisional, the final provisional, where the patient is going to see the difference at the end of it. This was done with CAD-CAM. We love CAD-CAM because it really helps us to come up with a nicer texture, copy maybe the anatomy of the teeth from the contralateral side, so wax up is not as difficult to create. I did that provisional stall model, and what you see here is that I have to carve, I have to do a platform shift on the medial aspect of my central incisor on the natural abutment in order to create more space for my papilla and center the midline that was waxed up at the beginning of my treatment. There are not too many things that are said, and basically, being myself a dental technician, I have a ways to communicate better my contour and show to my technician that maybe the abutment is too far out, and bringing that abutment too far out will create more recession than the adjacent tooth. So for me, the diameter of the natural tooth and the implant should be pretty much as close as possible. But the other thing is also to have the same height vertically and horizontally, so the abutment, both abutments support in the same way the same provisional. And this is crucial when we do any kind of high aesthetic and prosthesis in order to control the heights of the finishing lines in order to come up with contours that support in the same way the soft tissue. So now we are facing the final CAD/CAM provisional. We are just making the story short. So this is what we were able to come up with. And now it's a matter of communicating with Luc, that he's in Belgium, and ask him, hey, listen, this is my ideal provisional. I do not want you to make more pressure on the lateral incisor because I have my implant just below. So if you make more pressure, I'm going to perforate it. I don't want to do that. So here is crucial to really communicate the contour in order for him also to have an idea what is going on in the medial aspect of the central incisor, where I did a platform shift and where he will see a weird contour as far as the root. So you can see that maybe that papilla is the most difficult to be able to create, and this is due to the precision about the pressure that is necessary to come up with that. So we come up with few videos, and we have a video 1 year out. As you see, I choose a gold abutment because with that system I was not unable to have a titanium one. So we had to customize it in order to come up to that. But you can see the difference. I took by then a final impression, and we use, if you graft, you can treat your implants as if they were natural teeth. You shouldn't be worried about. So we take that second impression, and we take the final impression of the abutments. And the idea here is to really be able to create some dies, some galvanized dies, and in 24 hours I can have a galvanized die that can really fit my provisional. To do this type of technique, why do we do that? We do that in order to create the emergence profile. So what we do is a pickup provisional of the restorations in the mouth, and once in the lab, what we do is those galvanized dies. Why galvanized dies? Because they are in metal.
Yeah, you can't do this, and they will break when you take off the model of the impression.
Yeah,
so,
and also they will wear.
Just because of the stability and the precision. It's an old-fashioned way of working, but it's worth doing it.
So basically, in this model, what he has the provisional. Obviously, the patient is waiting for the provisional in the waiting room until we create that master model. But basically now, Luc has everything under control about what we have done so far on the case, and he only has to create the porcelain.